Very impressive, Leslie. Our last speaker in this session is Hilary Seligman. She will speak on community programs for chronic disease and seniors. She is the Senior Medical Advisor and Lead Scientist at Feeding America. Welcome to the podium.
Okay. Thank you for having me today, and also thank you to all of the presenters who preceded me who just really teed this up beautifully. I am going to now try to take some lessons from the previous 3 or 4 speakers and really try to connect the dots and share with you guys the way in which these programs are really important both for senior nutrition and also for the prevention and management of chronic disease. So I'm going to review just a few things here that I know have come before, both by Craig Gunderson yesterday talking about food insecurity, but I think there are a few elements that we need to review in order to really understand the connections between food insecurity and chronic disease and why these community programs are so important. I will remind you that 5.4 million seniors are food insecure, and there's a very important difference between the concepts of hunger and the concepts of food insecurity that are important for understanding how food insecurity is important for chronic disease. Hunger, by our official definition, is a physical sensation that all of us experience, no matter what our financial access to food is. It's that uncomfortable, painful feeling that many of you might have right now if you skipped breakfast. In distinction with food insecurity, which is officially defined as an economic and social condition of limited or uncertain access to adequate food. Now, the reason why I think it's so important to stop here and reflect on the differences between being hungry and being food insecure is that people who are food insecure engage a number of coping strategies in order to avoid the physical sensation of hunger. This is hardwired, it's physiologic. Rodents do the same thing. This is what we as humans and animals are designed to do, to avoid going hungry. And in particular with food insecure adults, we have to worry in the context of the prevention and management of chronic disease, which is so important in the senior population, about particular coping strategies such as shifting dietary intake towards low-cost foods that, as we heard many presenters before discuss, tend to be fewer fruits and vegetables and more fats and carbohydrates. Fruits and vegetables are much more expensive calorie for calorie than carbohydrates and foods with added fats. Food insecurity adult individuals eat highly filling foods that they're sure are going to fill them up for the rest of the day, particularly if they don't have access to a second or a third meal of the day. Concentrate their dietary intake on a small variety of foods that are either comfort foods or that people are very confident will keep them full. A big effort to avoid any food waste, and then binging when adequate food is available to keep them healthier during anticipated times of food inadequacy in the future. Now, there are many other coping strategies that people use, and there are many examples of coping strategies that really build resilience in food insecure adults and seniors. But I'm pulling these out because these are the ones that we really focus on in terms of increasing risk of obesity and diabetes and other chronic diet-sensitive disease. Now, once you are chronically ill, these coping strategies also make it more challenging for you to manage your illness. And this is really starts a cycle that is very, very challenging for the food insecure adult to deal with. So if you start at the top here, think of your food insecure senior. They are adopting a number of coping strategies, and we've talked a lot here about the reduction in dietary quality, shifting towards low-cost, nutrient-poor foods. Something that we don't talk as much about, but is equally important in this world of food insecurity and chronic disease is changes in the way you eat. I mentioned binging when food is available and fasting when food is less available. I mentioned the intense concentration on avoiding food waste. And then we often forget to think about the extreme stress that an individual is under when they don't have adequate money to afford food. And I'll talk a little bit more about these later. What happens is when you adopt these coping strategies, you're at higher risk of chronic disease. When your chronic disease burden increases, we know that your healthcare expenditures go up, and particularly for seniors, your functional status goes down. For younger seniors, we think about employability as going down, but particularly for this population, we worry about functional status. As this happens and household income decreases as a consequence of your healthcare expenditures, your pressure on your household budget and your spending trade-offs go up, and this makes you more food insecure. And so I will emphasize here that this is a cycle, and once you enter this cycle of food insecurity and chronic disease, because of the high costs associated with healthcare expenditures in the US, it's very challenging to get out of this cycle. So as I mentioned before, food affordability is really playing a role in the reduced diet quality. Stress and the competing demands really make it challenging to both manage your food insecurity and manage the needs of your chronic disease. So if you can imagine, if you are a senior with diabetes and you have the choice of paying for your glucose test strips or having another meal to eat, the choice is often, well, neither choice is good. We want people to have access to both. But we also see that the focus on finding the next meal crowds out other things because you only have cognitive bandwidth for a certain number of things no matter what your age is. And what we really worry about is food insecure adults spending so much time and energy on where their next meal is going to come from that it crowds out things like taking their health, like registering for benefits, and doing all the other things that adults need to do in order to keep themselves healthy. So rather than take you through a bunch of quantitative numbers, I'm just going to illustrate the experience of food insecurity among seniors, and particularly the coping strategies that people are using by a few quotes. As I talked about reduced food intake with all my expenses, sometimes I have to go to bed without eating, but I am used to it. These are all quotes from seniors. Episodic food availability. There were times that if we found food for lunch, we didn't have food for dinner. Sometimes our daughters would help us. That would give us a loaf of bread, and they would help us with a little bit of food. It's sad and painful. Sometimes we run out of things towards the end of the month. A very frequent experience that food is available at the beginning of the month, but reliance on community programs or on informal social networks for food at the end of the month goes up because food budgets have been exhausted. Dietary quality and competing demands. I buy the medication first. I cook macaroni and put some sauce on it. No protein, not enough protein. I worry a lot because of nutrition and health. I don't have the money to buy the food I need. And then I do want to pull out just one example of these methods of resiliency. There are so many people who are living in food insecure households and food insecure seniors who have found incredible ways of coping with food insecurity, and I just pulled out one. Sometimes I don't have anything here and I don't want to tell my children that I'm in that situation. I'll go to some of the sisters' apartments from church and they offer me food, and that's how I can get something to eat. So very common reliance on social networks. As others mentioned before, compared to seniors who are food secure, seniors who are food insecure are much more likely to be chronically ill. They're more likely to have depression, heart disease, asthma, and congestive heart failure, also diabetes, and a host of other diseases. Now, what is complicated here, and I will hearken us back to that cycle that I showed you in the beginning, is that we know that food insecurity predisposes people to these chronic diseases, but also that these chronic diseases, by taking money out of your budget for food and for seeing your physician and emergency room visits and hospital visits, draws out lots of money out of your budget and predisposes people to food insecurity. This is a complex relationship, and I think we're only just learning which arrows are bigger, which direction is predominant in this relationship. So there are two, classically as a physician and someone who sees patients in the safety net primary care setting, we are used to focusing our attention, once people develop chronic disease, here on trying to prevent complications, prevent declines in functional status, and prevent the need to increase healthcare expenditures for our patients. But really, when you're talking about food insecurity, the logical place to intervene is up here in the community. And to the extent that we can resolve food insecurity, we can allow our clients and patients and our seniors in our communities to avoid these coping strategies that are making the prevention and management of their chronic disease more difficult. And so that is really the goal, is to the extent possible, particularly in the food insecure population, to move our interventions earlier. And that means moving our interventions into the community, such as some you heard about today. Now, two quick notes for the senior population. The first is that food insecurity can be a very socially isolating experience. Being a senior itself can be a very socially isolating experience. And so when we think about this, I want us to keep in mind how important this social isolation is for health and for preserving people's ability to live independently. And we really need to think about our community interventions also as having this bonus of reducing social isolation. The second, I'm not sure if Craig Gunderson discussed this yesterday, is that when we look at food insecurity among seniors, is that there's this interesting demographic trend where among the senior group, food insecurity actually declines as you age. And I think a lot of this is because as healthcare providers and as social service providers, when people start to get frail, we use this as a reminder, or we use this as a trigger to activate community services that resolve or assist with people's food insecurity, even though food insecurity wasn't something that we had even picked up on, particularly in the clinical setting, or thought about. So for example, when my patient tells me that she's not able to get to the grocery store anymore because of her limited ambulatory capacity, then I might activate Mom's Meals or Meals on Wheels or something like that. But nobody traditionally has screened her for food insecurity 15 years ago. And it may actually have been that her inability to access healthy food started many, many years before she had a physical limitation. And so we really have to take note of this demographic trend and start to think about food insecurity earlier among the elderly and not just among people who've developed frailty. All right. When we're thinking about community programs for seniors, we like to divide our food insecure population by where they live and what capacity they have for independence. And we talked some about food pantries and congregate meal sites today. These are examples of interventions that work really well for seniors who are not homebound. There are people who are homebound and can cook, and these community-based programs include things like home-delivered groceries are targeted at this population. And then those who are homebound and cannot cook, community programs targeted there generally offer home-delivered meals. The importance of there are multiple things that are important about thinking about our senior population this way. One is that it gives us opportunities to really target our health interventions as well. So for example, you could think about, and we are, you can think about, and we are doing chronic disease prevention in places like food pantries. These are places that attract seniors many times, month after month after month, for years or even decades, because as Leslie just mentioned, food pantries have become places where people are going not just for emergency food, but for their chronic needs. So, for example, we now have a project that provides diabetes self-management support in the food pantry. So if you can imagine, if you're coming to the food pantry every month anyway, and in the food pantry we can help check your hemoglobin A1C or your blood sugar. We can help make sure that you're connected to a primary care provider. We can give you diabetes education. And most importantly, because food pantries have the capacity and have the expertise in the distribution and management of increasingly healthy food and food that is appropriate for chronic disease management, we can offer food that's good for your health. So these are just some examples, and in terms of the scope and scale, Just Feeding America provides 127 million meals to 7 million seniors annually. So lots and lots of community-based programs. As I said before, the real goal here is to start moving our interventions earlier so that we can impact these coping strategies. And to the extent that we can help people not have to engage these coping strategies, we also allow a much greater reduction in stress. We also allow people's stress level to go down. I will mention too that there is quite good evidence that the availability of home-delivered meals in a community is very highly associated with people's ability to maintain independence in their community. And we really do have good evidence that these types of programs, if they're allowing people to remain independent in the community, are cost-effective. And with that, I will stop.
Thank you to all 6 speakers in this session, especially thanks to you, Dr. Seligman. I am very pleased that all of our speakers have given us great examples of innovation and commitment of the private sector to improving nutrition for seniors in America. All of our speakers will be back after your break, which I'm sure you're looking forward to, and I know we will have great questions for them. Could I ask the speakers to come back a few minutes early just to get lined up? Thanks again.